per role will be leading this session. So I just want to thank you guys for tuning in. I've been checking out the views on Facebook, and it seems like we've had a lot of people tuning in. So really excited about that. On another note, I want to say to you all, thank you for listening in with me over the course of the last 6 weeks. I know we've done a lot of video sessions, and have been so grateful to all of you who have continued to tune in through many different topics. So with that being said, Michelle, I'm going to pass it over to you.
Great, thank you for that, Isaiah. I just wanted to introduce ourselves, but start by kind of thanking everyone for joining us. Like you said, my name's Michelle Sims. I was the chair of the DO Advisory Board and just, like you said, transitioned out. And we're here to recognize National Osteopathic Medicine Week, and hosted by the American Medical Student Association. This was the first year that the ACGME merger occurred, and AMSA wanted to provide some information for students that were interested in becoming physicians on how that's really affected everyone. We put these talks together to give you all some insight on what the training and practice experience is like for DO students. I know many students and schools were concerned about how the merger would affect this year's match. For the viewers who don't know what the match is, in September, all of us fourth-year medical students applied for residency programs. We spent a few months interviewing, and some of us auditioned at programs. And then in March, March is match month. So that month, this year it was March 20th, we all ranked the programs we were interested in attending. And those programs also ranked us, and a computer system actually matches us. So it's a surprise for everyone. But with the merger, there's now a unified ACGME match for both DO and MD students. As expected with that switch, there's been an increase in the number of DOs that applied to ACGME programs participating in the NRMP match. And there's also been a significant increase in the number of DOs that matched overall into ACGME accredited programs. So it kind of was about the same as last year, and actually had a slight increase. So we did really well as DOs matching into PGY1 positions. And we have some of these students here today who volunteered their time to talk to us more about their experience with the match. And for those of you tuning in, you can actually leave your comments or questions that you have in the chat, and we'll get to those at the end. So I'd like to just start by thanking our class of 2020 speakers. I know that you guys are still busy, and I appreciate your time being here today. I'm just going to start by allowing you guys to introduce yourselves, and just kind of asking everyone. Everyone here is at the Alabama College of Osteopathic Medicine. So I guess you can skip the medical school you're at. But I'm just going to start by having you kind of, sorry, that's the NRMP match data, and kind of showing the increase in positions. But this is everyone's information, that our panelists and where they match and what specialty they match into. If you also want to share where you went to undergrad and what you majored in, and then kind of discuss your specialty that you chose to.
All right, well, I'll go. My name is Kerstin Olivier. I am a fourth-year student from ACOM, as we mentioned, and I am going to be moving into psychiatry at the University of Virginia. I went to Pepperdine University for undergrad and got my, I majored in chemistry. And I currently call home St. Pete, Florida, so I've kind of been all over the place. I also participated in the couples match with an MD student, so I think I'll touch on that a little later as well.
Hi everyone, my name's Marcia. I matched family medicine into a program in Athens, Ohio. Originally from Maryland, I went to Duquesne University in Pittsburgh, Pennsylvania. I was actually a music technology major. Also did a post-bac program up at Hofstra University in Long Island, and have been down south at ACOM since then for medical school.
So my name is Shrikant Parthasarathy, and I was born and raised in St. Louis, Missouri, where I went to Truman State for undergrad, and I majored in kinesiology. I matched into anesthesia at University of Central Florida, Ocala, which is a PGY2 position, and I'll be doing a prelim in Mount Sinai in New York City.
Hey y'all, my name is Brock Daughtry. I am originally from Perry, Georgia. Went to Auburn University for undergrad, where I majored in biosystems engineering, and then went down to ACOM, and am going to be heading to Brookwood Baptist Health in Birmingham here in a couple weeks.
Great. And I already introduced myself. My name is Michelle Sims. I went to the University of West Florida in Pensacola, Florida for my undergrad. I actually majored in psychology and just took the prerequisites for medical school. And I ended up matching into physical medicine and rehabilitation at the University of South Florida. So I'll skip over this. I wanted everyone to see your credentials. The first question that we really have is, as a pre-medical student, why did you decide to go the osteopathic route?
So when I was in my post-bac program, I wasn't really familiar with osteopathic route. Was talking to a pre-health advisor who had mentioned looking into it. I went to a couple open houses at some of the medical schools, saw some OMT demonstrations, and I really fell in love with OMT. I also love the holistic aspect to an osteopathic degree, which really starts from day one, and you kind of see that through the first 2 years and continuing through your third and fourth years. So the combination of getting to learn OMT and having that extra holistic approach to patient care was a big push for me to go the osteopathic route.
Awesome. Thanks, Marcia. I actually found out about osteopathic medicine pretty early. In my undergrad. I think I was probably a sophomore in college, and I was fortunate enough I had joined AMS's pre-medical chapter there and started attending conventions, and they had a lot of speakers that kind of spoke on what OMM was. They had demonstrations that really sparked my interest. And then I think what really sold osteopathic medicine for me was Dr. Hayes, who was our OMM chair at the time. He was so passionate about osteopathic medicine and what it could provide for patients that I think he could have really changed the mind of anyone who was a naysayer about OMM. So I think just hearing how it really has changed lives. And then if you ever weren't sure, I think the first year of medical school, a lot of us had somatic dysfunction at some point, just from all the studying. It's not natural to study as much as you do in medical school. So I think just, and then going and we had fellows and physicians that treated us all the time, as well as other students. So I think having that really makes you appreciate it. So our next question was, why did you choose your specialty? And did your desired specialty ever change? If so, what or who inspired that change?
So I chose family medicine for many reasons. And instead of wavering back and forth throughout third year, I think that my rotations actually strengthened my desire to go in family medicine. I would be on rotations and I'd be missing things that you would get in family. So in OB, I missed seeing other types of patients. In peds, I missed seeing adults. In ER, I miss being able to have more conversations, because in ER, you got to be in and out, and that's how the process works. I love family medicine. It's a very broad spectrum. I'm more of a generalist at heart. I like being the central of the hub and kind of consulting out to get that person's overall wellness on the right track. So I think that for me was a big sell for family medicine. allows me a chance to talk with patients, get to know them on a personal level, but also having some time for some procedures as well. Doing EKGs, joint injections, derm procedures, and ultrasound is getting really popular too, coming through family medicine residencies as well for maybe some of those more particular smaller joint injections. So it gives me a chance to have that broad spectrum type of medicine, as well as being able to use my hands a little bit as well.
So I chose anesthesia actually not until like my end of my third year when I did my rotation, but going into med school, I was sports medicine, especially with my kinesiology background and playing sports. It just made sense to do sports medicine through internal, family, or PM&R. But then I really started to, I think I just didn't know what other specialties were really out there. But then during my third year rotations, you really, you'll see, you'll probably jump specialties like more than you ever thought you would. But I did my anesthesia rotation and really thought that I realized I valued one, the OR, two, being like in an acute setting, doing like critical care or acute procedures, and also like the opportunities in anesthesia to, you know, have your own patients. If you ended up doing pain management or something like that, where you really can get to know your patients. So it kind of brings together all of those things. Also, the specialty inherently brings more laid back people, and I consider myself pretty laid back. So it just made sense. I fit with the crowd that I was around, and you guys will all see that when whatever specialty you pick, you'll probably, you fit into that, population of people that go into that field personality wise. So yeah.
Great, thanks. I guess I would also add for myself, initially I thought I was going to go OB-GYN. I thought that, I think I was 17 when I decided I was going to be an OB-GYN. And then I started medical school, and I think it was like probably during our reproductive classes where I like sort of knew that it probably was not the specialty that I wanted to go into. And I would say a lot of other medical students that I worked with or I was friends with loved every single specialty. And it was really hard for them to make that decision on which one was right for them during like clinicals. For me, it was kind of the opposite. I didn't necessarily love every specialty, which it helped because whenever I found the one that I really loved, I knew like for sure that's what I wanted. And it was actually from sort of a personal experience. One of my cousins was in a car accident, had a traumatic brain injury, and that sort of brought me to the field of rehab. I didn't really understand it from like, patient care perspective yet. So I spent a little bit of time just like volunteer, or not really volunteering, but shadowing a physician during my second year of spring break, which seems a little crazy to spend spring break doing that, but I wanted to make sure that the electives I chose during third year would be exactly what I wanted. So I knew then that I loved that field. So that's sort of my journey to PM&R. Let's see, what's next? As a pre-medical student, it can be challenging to find physicians that allow you to shadow them for observation hours, and sometimes even more challenging to find DOs. What advice do you have? So this is a great question. I remember being there and feeling like, as a pre-medical student, you're at the very bottom of the totem pole and no one wants to take you and you're just in the way. It's not true. There are physicians out there that do love teaching. You just have to keep reaching out, keep trying to find the ones that really do care. And they'll end up being mentors, for a long time, because those are great connections and that you can make. So it's a really tough time to find DOs. I know someone during the last panel asked, how do you shadow during COVID? Like you don't. There's really no way. Like we're not even as medical students going out and working right now. So that's tough. I don't know if there are any like telehealth, for pre-meds. But, just do what you can. And if you want to try and reach out to physicians, especially ones that aren't like in the ICU and emergency medicine, ones that are in a clinic setting, and say, hey, when your clinic opens, I'd be interested in shadowing, something like that. But everyone is very overwhelmed in the healthcare field. So I'm sorry that you are applying during such a tough time, but just keep it up. And also, I would mention that national convention. I went to a few of AMSA's national conventions, and there are so many networking opportunities there where you can meet other like future medical students, current medical students, residents, and physicians. So you can and usually those people there are interested in networking. So taking the time to go and really meet and network would be a great way to try and connect with physicians that you could potentially shadow in the future. Does anyone else want to add anything?
Yeah, I'll add something. I think what I ended up doing, which I mean, as a lot of medicine is, it's a lot about who you know, and especially in the beginning. So I think using the connections that you have, whether it be your mom's friends, doctor, or whoever can get you in with someone, use those connections, because that ended up working for me. And I found a DO through a long kind of convoluted route, but it was ended up being someone that knew someone. So just use the connections that you have. And I think that could be hugely beneficial.
Awesome. Thanks, Kerstin. So our next question is, have you found that people in the family, let's see. Sorry, it's kind of blocked by our screens. Have you found that people in fields outside of family medicine have been accepting of the application of OMM techniques, and did you use any during your auditions? And I guess I can start by answering that. Luckily, I feel very fortunate in that I'm actually in a field that is very OMM friendly or DO friendly. So I actually did use OMM during my auditions. Actually, quite a few of the residency programs that I applied to either have a direct OMM, like, I guess, incorporated into their residency program. So it was either months of OMM during their intern year or during 1 year of their residency, or they had a clinic that you could do as an elective. And so during my audition, for example, at Michigan State, they had it set up so I would spend a day, and it was sort of a sports medicine clinic that was combined with an OMM clinic. So they had DO physicians there that I was working under, and fellows that would allow me to, like, they had one fellow that was like, okay, this patient's complaining about like low back pain, can you check their anominants? And so I just I checked, their ASS, PSS, and was like, yeah, it looks like they have an anterior anominant on, this side. And then they were like, do you want to treat it? So I was like, sure. And so they're like opportunities where you can really shine on an audition, where Michigan State does have MD students that come through that are applying, but that might be a way as a DO student to really stand out. So I felt accepted in my field for sure.
So I was able to use OMT in a couple different rotations. Of course, my family doctors were very open to it. But I also actually used OMT during an ER rotation. It was a slightly slower shift. And I happened to be with the DO, and I said, hey, I think this patient has some somatic dysfunction. I don't think this is an emergent thing. It's kind of slower. Do you mind if I go in there and teach her some different stretches and kind of do some stuff with her? So I think that if you find the opportunities, go for it. Be confident in your abilities. Know the definition of OMT, know when you would use it and when you wouldn't use it. I think that that's a big thing that I noticed when I was speaking with my MD preceptors who maybe weren't as familiar with OMT, or were like, what is that? Like, what would you even use that for? And so just be like, oh yeah, I mean, you can use it for this and that, and just kind of stepping up to the plate and just saying, hey, do you trust me? Let me try this. I even had my neurology preceptor actually came in and said he had something wrong with his back and asked me to actually do OMT on him as well. So I think that if you or just confident and just explain the uses for it, I think that preceptors will be open to using it. I used it during my auditions. Of course, it was family medicine programs that I specifically were looking at that had a lot of OMT already, but we were able to use it in an inpatient setting and more acute type of settings, which sometimes it's hard to maybe know when you would or wouldn't use OMT. Also had a chance to do it on newborn babies who were having some feeding difficulties. So there are a lot of different ways you can use OMT. And I think that if you just step up to it and know your skills, I think it's something great to be able to kind of present as another clinical tool that you can use.
Perfect. I had a question from the audience about what an anomaly is, which I'm sorry, I know that we have a lot of pre-medical students viewing, and it was rude of me to just throw out medical jargon without explaining. So it's something that throughout medical school, you'll be learning, and it'll just be second nature. I used to, not know what a clavicle was. So innominants basically make up your pelvis. So when I'm talking about innominate, like we usually do this, if you guys can see me, if I say it's like anterior, posterior, I'm looking at landmarks. It's not voodoo science. I'm literally just looking at, where your iliac, what are the common terms? I'm looking at where your hip bones are, and if one is out of line, a lot of times it can happen from lifting something too heavy, from slipping and falling. A lot of times people have it in pregnancy because of like the change in the way that they walk when carrying. So it's so common. Actually, I literally spent the last 4 days treating my boyfriend because he was squatting, and now he has sacral torsion and a posterior innominate, and he has all these issues that I've been treating every day. So it's very useful. It's something that I can use every day if I have to. And I'm sorry that I kind of jumped over that. And I also should have mentioned, we really have been saying OMM and OMT a lot, OPP. So OMM is osteopathic manipulative medicine. OMT is osteopathic manipulative treatment. OPP is osteopathic principles and practice, which all just kind of are the same abbreviation for us and how we say our treatment with osteopathic medicine. So I'm sorry about all of that jargon. I hope the pre-meds are keeping up with us. If you guys have questions, just throw them in. It doesn't matter if you feel like they're silly. We appreciate it and want you guys to understand exactly what we're talking about. So the next question was, what recommendations do you have for current OMS 1 and OMS 2 students to strengthen their applications and become more competitive?
I think that the most important thing, and I'm going to say it like this, know thy specialty. So every specialty has different things that they're looking for, different things that they find that's maybe more important. And then kind of across the board, you're going to see specialties all are looking for, some similar things. So if you Google 2018 NRMP Program Director Survey, there's a breakdown of every specialty, and it shows what they find most important and what they're looking for on the applications. So of course, you're going to see scores are really important, right? So your board scores, you have to work on those, and those are going to be some of the top things. But specifically for family medicine, one of the number one thing they actually look for is commitment to the specialty. So you're going to find little things like that. And so my best advice is to, use things like that to kind of see what your specialty is looking for. You can't go wrong with leadership. Get plugged into clubs that you have at your schools, get involved, try to see if you can hold a leadership position with that. Volunteer as well. And other specialties, research is more important than others. But I would also say, see if you can find an upperclassman, if you will, who already matched or is kind of leaning towards that way, maybe did auditions or kind of starting that track. I think it's really important especially in medicine, to have mentors to kind of bounce questions off of, because they're going to be able to tell you little things and little tips of the trade and stuff for your specific specialty. So I think definitely knowing what's important for your specialty. Sorry, board scores are important too, and get a mentor that you can kind of ping pong ideas off of, and ask any questions that you have kind of along the way.
Wow, Marcia answered that really well. So I guess I'm going to just talk about anesthesia in particular. So one, anesthesia is, I would say, middle ground regarding competitiveness on the continuum of all the specialties. You'd see their scores are on like the average mark for the USMLE step 1 and step 2 for people that matched in the like past so many years. One, a lot of OMS, I guess, 2s are considering like if, should I take USMLE for anesthesia or should I just take Comlex? I would, with the merger in particular, say that definitely try to take the USMLE if you can. Obviously, if you're not doing well on your practice MDME exams, don't like force it, but I would shoot to take it because it definitely opens a lot of good doors, especially since there weren't a ton of AOA anesthesia programs to begin with pre-merger. There aren't a ton of programs that are like only looking at DOs. So most of them are ACGME that are looking at all these people that took USMLE because they had to. So definitely take USMLE if you are considering anesthesia. Like Marcia mentioned, all these specialties now are pretty much wanting a well-rounded applicant versus someone with crazy board scores but doesn't really have anything else. So this speaks for other specialties too, and I would just get involved in whatever specialty it is, if it's anesthesia or surgery or PMON, whatever. If there's an interest group, do it. Get involved in like a chair position if they have one. This shouldn't be like a chore. Hopefully it's fun, meet new people or whatever. Also, in regards to research, anesthesia is not super research. Like the program directors aren't like dying to have research. If you have it, it looks great. It shows your commitment to the field. I personally did research in non-anesthesia related things, and they weren't even like groundbreaking published things, but they were just case studies that I found were interesting during my third year clinical rotations. And I like presented them, and that it got brought up in interviews. Like, that's awesome. What, like, it was just like an interesting case that was kind of like quote unquote rare. So I just thought I would do it. That shows that you're, more than just like taking a board exam kind of applicant. You are interested in other things. This may be a little too ahead, but during your third or fourth year, I also recommend going to the anesthesia or whatever specialties annual conference. I went to the anesthesia conference the fall of my fourth year, and there's a dedicated meeting for just meeting with program directors, etc., residents from all over all these residency programs, which really puts a face to your name. That was right around the time that we submitted applications. So I could say that I got 1 or 2 interviews just from simply communicating and like talking to program directors and residents at the program, at the anesthesia conference. Yeah, that's all I have right now, I guess. So,
Michelle, can I jump in and say something as far as surgery goes? So research gets brought up a lot, especially in other specialties, but surgery, for whatever reason, it always seems like there's a huge push to do a lot of research. I had one thing to research that I did. I did a small little case series as a third-year student. I wish I had more, but especially applying for surgery, general surgery, you really need to have something. It doesn't have to be earth-shattering. You're not trying to change the face of medicine, but something that when you go to an interview, you can talk about, because it gets brought up at every single interview. As an applicant, you always want to ask the program, and the program is always going to ask you as an applicant, hey, what do you think about research? What are your, and as an applicant, you want to know, what are my opportunities here? Because, you start looking at fellowships and that kind of thing and where you want to work. And, some people are really dedicated to research. That's not me. But as long as you have something on there that you can talk about, that's really what you want. So you definitely need 1 or 2 little things. Like I said, mine was a little case series my roommate and I did. presented it at the statewide conference. So it was something to talk about anyway. And you really need to have one or two things, especially applying for surgery.
Yeah, I have to agree with everyone. And really, this is going to vary so much depending on what specialty you're going into. So for me, I'm fortunate that this was a specialty that for PM&R, it's not emphasized board scores. Like we don't, they do want you to pass the first time, but that's not going to be on like the high end of what they really care about. Same thing with research. It can definitely help you, but I ended up finishing without any research, and I'm here and I matched to my into my top program. So I would say that it's they for my specialty. I would say that they care most about your personal statement, your letters of recommendation, and your evaluations from clinical years are like what's crucial. And they want to see that, like Marcia said, they want to see that you're committed to that specialty. So my biggest advice would be to show your commitment early. So if you can, like I ended up like coaching the Special Olympics during undergrad. That would be tough to do during medical school. So don't take on too much. But I did work with like adaptive sports. And I ended up also doing like music festival volunteering where I worked with the ADA to help people with disabilities. So like things that really speak to PM&R. Like I had an interview where they grabbed my application and the first thing they said was like, I haven't seen an application that screams PM&R so much. So you want to show them that. And it's not something that you did last minute and you've done for a month. If you can get involved early and really find unique things that are related that you can that you actually enjoy doing. That way, whenever it comes up on interviews, you can actually be passionate about it. I would say that would be that would be a good way to strengthen your application. So our next question is, there are some residencies that have all MDs and currently appearing to be MD biased, but have stated that they accept DOs. Since it can get expensive applying, is there a good way to determine if this is a front or that they actually are interested in DOs?
So that's actually a really good question. I think the whole idea of the merger is to kind of even out the playing field a little bit between DOs and MDs. However, I think that's going to take some time. And so we're still kind of in this position where there are some very MD heavy programs, some DO heavy programs, and kind of a mix in between. So because I was participating in the couples match with an MD student, I had to be pretty vigilant with my research. And so I think that's kind of the best way to determine if they're willing to accept DOs is to see have they accepted DOs in the past and how many of them are currently in the programs. So those are all online. They usually have the current residents and where they went to school and whether they're DOs and MDs, and that proved pretty helpful. I think that's a fairly good gauge as to whether or not they'll take DOs. If they have one DO in all 4 of their classes, that might not be the greatest, MD friendly program. But if there's 1 or 2 or 3 every year, I think that's a fairly good good idea. That's not to say that if you apply to an MD heavy program that they're not going to interview you. I interviewed to a couple just as kind of reach schools, and I got a couple of interviews that way. Maybe it was through the couples match and whatnot, but once you've got an interview, you're in the door. So if they think that you're willing to be interviewed, then you must be meeting their requirements. So I think of course, you don't want to apply to every program that there is, but kind of doing your research and being aware of have they taken DOs in the past is a good kind of idea when starting the process.
So I actually interviewed at several programs that were very MD heavy. I did my research and I chose mostly programs that had a mix, but Kerstin just said it best is, once you're in the door, like once you've got that interview, then they don't, they've already looked past the MD versus DO thing. Once you're there, then you're good enough on paper for them to spend their time and spend their money interviewing you. So they're not going to interview somebody that they know is for sure they're not going to take based on what 2 letters come after your last name. One really good way to do that, for the third years this year, it's kind of tough. I know the COVID thing, it's all kind of crazy. But for me, what really helped me out was doing some audition rotations at places that were MDheavy. I got a couple interviews and I asked, and just talking to those guys, they said, you wouldn't have gotten this interview if you didn't audition here. Both of those places had very few DO students in their surgical program. They had some foreign medical grads and they had DOs in other specialties, but for whatever reason, surgery is just lagging behind. But it's coming around, and I really think the merger this year is going to change that a lot. Maybe not, this coming match or the one after that, but you start looking 3-4 years down the road, and I think it'll start leveling out pretty good bit. Along those same lines, you have to be smart where you apply. If you're applying to, you're not going to get into, well, I'm not going to say you're not, but it's not a great chance that you're going to get into a MD academic program that's never taken a DO before, and they're just, they've been a program that's been around for 80 years and never had a DO. Your chances of getting in, I mean, you can do it, you can certainly apply. And like I said, once you get in the door, especially if you audition there, once you get in, they don't care anymore. But it's, it is a pricey thing. But then again, at the end of the day, when you start looking at the money you're spending for school, the money you're spending sending out applications is just a very small drop in a very large bucket. So, I know money gets tight, but at the end of the day, this is what you're trying to do for the rest of your life. So, if you got to splurge somewhere, splurge on your applications. Go ahead and cast a far net and see what happens. But once you're in the door, especially auditions in surgery are a huge thing. They can really help you out getting some interviews at places that you wouldn't have gotten otherwise.
Great. Those were perfect answers. I agree 100%. I would also maybe say, if I've never been out west, I've never once been to California. Maybe it was just me personally, but every single interview I got, I think the farthest west I went was like Arkansas, which is not west. So, if I could go back, I mean, I still would probably apply pretty broad because, for me, I was more concerned with making sure that I got a certain number of interviews. But, if you know that you don't have any ties at all to like, Texas or California, there's certain, I feel like, states that are very hard to get into if you don't have a connection. That can be a way to save money if you feel like you're competitive everywhere else and that you're just trying to limit your applications. But otherwise, I applied everywhere, and I ended up going to New York for the first time and other places. So you never know where you're going to get an interview, but I would say that geography is something that they do, I think, take into consideration when offering interviews. So our next question is for people still on the fence about taking both boards, so both USMLE and COMLEX, this next cycle. What would you recommend, and what has been your experience? Did taking both boards help or hinder you?
So I think I have a pretty strong opinion about this, but I'm sure there's others out there that can speak opposite. But I think if you have the ability to take it, you should take it. I think it was a huge asset in my application, and overall, I think it 100% helped me. Again, I was in the couples match, so I think that played a role as well. One of the main reasons why I did take it in the beginning was because when I started medical school, I had no idea what I wanted to do, and I didn't want to be limited by only having taken the COMLEX if I wanted to do a more competitive specialty. And I ended up in psychiatry, which is becoming more competitive over time, but certainly isn't the most competitive specialty now. But I do think it opened up a lot of doors for me. I think it kind of comes with a couple of caveats as far as whether or not you should take it. As Shri kind of mentioned, you want to make sure that if you take it, you're doing the best that you can and doing well on it. So if you take the practice exams and you're not scoring where you would like to score, you think you're going to do poorly, then I would suggest not taking it. Also, if you're kind of set on doing something more primary care based, like family medicine or even internal medicine. Those specialties may not require the step as much as something like anesthesia or surgery or even psychiatry to that extent. I do think something kind of interesting that I encountered on my interview journey. So my boyfriend is at an MD school, and his dean was a former program director, and he wanted to meet with us as a couple. He wanted to meet with his students that are applying through the couples match. So I was a part of that conversation. And before kind of advising us, he wanted to get some information about our statistics and kind of where we stood before he could advise us. And he asked me, as you know, aware that I was a DO student, he asked me, did you take the USMLE step exams? And I said yes. And his response was a little bit eye-opening for me. And he said, good, I wouldn't know what to do with the complex numbers. And that's just coming from a former program director at a MD heavy program. And so as unfortunate as that is, and as expensive as these exams are, I think if you're going to test well and do well, it's just something extra on your application. And again, it's going to vary depending on the specialty and kind of how well you do on the complex and whatnot. But I think if you don't know what you want to do, that's kind of a way forward.
I think Kerstin answered that probably the best that I could have. I didn't take complex. I didn't take USMLE. We have to take complex because I knew that I was applying to PMON, so what I did basically was I reached out to some of the residency programs and some of the current residents and just asked them, like, did you take both? Do you feel like I should? And majority said, like, no, don't even worry about taking both. So for me, it was just kind of an added expense. And I'm like, I don't know, historically not the greatest test taker with standardized exams. So I felt like it was probably safer for me not to take the USMLE and just focus all my energy on complex. So that's what I ended up doing. So I think, but I would echo what Kerstin said about if you are not 100% sure, what specialty you're going to end up in, you may end up falling in love with general surgery, or, you may end up thinking like, oh my gosh, I want to be an ENT. And there's no way in some of those fields to get there, it would be extremely challenging without taking both boards. So I would take both if you're not 100% sure. Otherwise, if you know what you want to do and you're set on it, then just reach out to those programs to find out if it's really necessary. Would be my best recommendation. And I guess I also wanted to mention that it's going to pass-fail, which I have no idea how that's going to affect everyone going forward and when that exactly starts. But with it going to a pass-fail, maybe I would take it just because I feel like it's better odds for me. But if I'm being completely honest, I had interviews where people said that they were really impressed with my complex. And I was like, you must not understand complex. So I if I'm just being completely honest, sometimes that can help. Where if I had taken USMLE, they would be like, oh goodness, it would have been a totally different talk. So there's that.
I just want to kind of echo this from a surgery perspective. If you're going to go into surgery, you have to take USMLE. There's not really any other way to put it, especially now going to the merger and only having one match. You might could have gotten away with it when there's still an AOA match and there were only, DO students applying. But just about everywhere I went, people said it's a good thing you took STEP because now we have something to compare to, because they don't know how to look at the complex scores. They're pretty different tests, and the scoring system is completely different. When you look at the passing numbers and the max and the min and all that, the numbers are way off. So if you're looking at doing surgery, you have to take it. And that's orthopedic surgery, general surgery, ENT, ophtho, Most people that are in OB-GYN said they had to take it. Anything more, on that level that you just do. And that's so that those program directors and those people that's all they've ever seen, that's what they're going to know. They're going to want to have something to compare apples to apples. So you just got to do it.
Great. Thanks, Brock. So our next question is actually for Kerstin. It's about navigating the couples match. Did you feel like couples matching as a DO made it more challenging?
So the couples match is a stressful thing to be a part of. I think you need to make sure that you're set for the long haul to do the couples match, and having good conversations about it in the early on times are probably the way to start. We knew, my boyfriend and I, that we were going to couples match right out when we started medical school, so it was never really a conversation. But when you're talking about people in two very competitive fields, you have to be very sure, because your fates are tied. And the rank lists, kind of how that all works is you pair your rank lists, and then it goes down, and the algorithm matches you with the highest of the pairings that you had. Programs are so different from one specialty to another. So we had, a hard time kind of figuring out what that rank list was going to look like. And we had to make a lot of compromises. So I think as a competitive applicant, if you want to go to a top 10, top 20 school for residency, the couples match may not necessarily be the way that you want to go, just because it's hard. We matched, which we were obviously very excited about, and a lot of the time I was afraid to ask couples that I met on the journey, where on your list did you match? And just because of that, I will say we matched at our number 4 spot. So we didn't match super high up on our list. I mean, certainly high relatively, but that was something that we had to realize going into the process, was where we both were matched. As far as being a DO, I don't necessarily think it made it any more or less challenging. From a statistical standpoint, he was a lot more competitive. He matched into anesthesia, for your information. He was a little bit more statistically competitive than I was. And so that opened some doors for me and closed some doors for him. I would say I more had to do with our statistics and our applications than it had to do with the DO behind my name. At least I'd like to think that. But overall, I think it works really well. And if that's something that you're set on doing, it worked out. And we're really excited about being able to do the next 4 years together. And yeah, I think reaching out to programs, that's the best way that we went about it. If he got an interview or I got an interview and the other one hadn't, we reached out to programs, and we probably got 3 or 4 interviews just by reaching out. So certainly doable, and maybe opens up some doors that maybe you wouldn't have had if you were just applying by yourself. But again, it comes with the complex of pairing 2 applications. So it was a challenge, but exciting.
Awesome. Thank you for sharing that. I know, I only watched the video, but it seemed very complicated. So thank you for sharing your experience with that, Kerstin. So our next question was, what have been some of the challenges, if any, that you've faced as an OMS or an osteopathic medical student?
I think the biggest challenge that I've come across is just not really understanding what osteopathic medicine is, especially from patients. Patients love finding more information about their medical student after you've asked your questions. Oh, where are you from? What are you doing? How are things? And so I say, oh, I go to this school. It's an osteopathic medical school. And they're like, oh, so you're going to be a bone doctor, which is a very typical response that you get from patients when you say that. So I think it's just a matter of educating, oh, this is the type of school it is. This is kind of what we emphasize. There's 2 different degrees that you can, 2 different paths you can take in the United States for a medical degree. So I think that's the biggest thing, is just people just not really understanding what osteopathic medicine is, what it stands for. So my advice is, be an advocate for your degree, and set a good example for an osteopathic medical student, and show them that we have a lot to offer with their medical care. So I think that's kind of the biggest thing, is just not understanding what osteopathic medicine is.
Yeah, I agree with that. I actually, since I ended up going into PM&R, I felt like every route that I've chosen has been, something where I was explaining what osteopathic medicine was, and then I was explaining what PM&R is, just over and over. So it's I don't know why, but that's just kind of the route that I ended up going. So you get really good at kind of explaining how awesome the field is. And I would say for me personally, I think the biggest challenge that I faced would be during auditions. So when applying for auditions through VSAS, there were actually times where I went to apply and then I realized it would be $1,000 a week just to do a rotation at one program where, so that's $4,000. If I was an MD, it would only be 100. That wasn't often, and clearly that's not the program that I want to go to. But I think that was surprising to me. I'm really hopeful that with the direction everything is heading, that will change with the merger. But especially in my field, I felt like I got so much love, and I had a lot of MD interviewers who really said that they love DOs and that our physical exam is just so much better and so much more thorough. So I felt like it was just so surprising that we were kind of discriminated against by some programs, but hopefully that will change. So our next question was, how are third and fourth year rotations as an osteopathic medical student? Were your MD attendings accepting, and did they allow you to perform OMT?
So I think I had a very positive experience through third and fourth year. I had a lot of MD attendings, preceptors that I worked with. I didn't feel like there was any issue that I was, going to be a DO and I have an MD as a preceptor. I think they were very welcoming and open to me. I think I touched a little bit about this on the OMT previously, but I was able to perform a lot of OMT. I actually got into a really interesting conversation with a radiologist during my radiology rotation who was an MD, really explaining, because he was like, I don't really understand why that's even necessary. And I was like, well, let's have a conversation. And I think by the end, I kind of sold him that OMT was a nice little trick to have in your tool bag, and just knowing when it is and is not indicated. If a patient's coming in and they're crashing and you're coding a patient, I'm not gonna do some cranial technique while we're doing chest compression. So I think it's just knowing when you are gonna use it and when it's appropriate. And I think those are your opportunities to say, hey, we have this COPD patient hospitalized for an exacerbation, having some difficulty breathing. They're stable, they're on their oxygen, they're hanging out in their room. Do you mind if I go up and do some rib raising or do some other techniques to help with some of that breathing component? So I think that there are definitely ways and times where when appropriate, you can advocate for the patient. And I think that as an osteopathic student, that is your job. You're advocating for your patient. And if there's something that can help them and get them out of the hospital even quicker, that's even better. So I think just be confident in your skills, know when you can use it, and just be open to having conversations, because you may meet a little bit of resistance. But I mean, if you're explaining things well and you're giving them some evidence on how it's useful, I mean, I think that's a great conversation to have.
Awesome. I agree. I know that I was concerned about this question whenever I started at ACOM, because it's a school in Alabama, and there aren't too many DOs actually in Alabama, especially before our program. There really weren't DO programs. So, it was something I was concerned about. But actually, and of course, I ended up going to Pensacola, Florida for my clinical rotations third year. So I was kind of on the border of Alabama. But I would say even a lot of the medical students that I know that were at core sites there, they never had an issue with if you really wanted to do OMM, I haven't heard of a preceptor that said no, you can't, or didn't feel comfortable. There are some techniques like HVLA that are a little more, I'm a little more conservative with. But as far as muscle energy technique, counter strain, there are plenty that you can do, facilitated positional release, that are it's, very, like, even I think Dr. Hayes said this plenty of times, even if you have the wrong diagnosis, then you're just doing an indirect technique, or like you're still helping them just by, working on them. And it's something that if you explain that to your MD attendings, kind of how, how you're able to use it and how this could help your patient, I think really I never had any kickback. And I had plenty of opportunities to use OMM during my rotations, and I was very accepted. So next question is, I think this is my question. So did you have any leadership experience with AMSA at a local or national level? And I don't know if anyone else did. If you did, then you can speak after me. I actually started with AMSA back when I was an undergrad. So I think I was maybe a sophomore in college, and that's when I started really getting involved. I started going to national convention, I think in 2014, back when it was in New Orleans. And I became the secretary and then vice president. And in medical school, I joined our chapter here and was the first year representative, and then took a national position. So I would say that in every step of my application, so as a pre-medical student, I think it was something great to add to my resume. And then as a as a medical student applying to residency, it was something that I was still able to, add onto my CV and use as a talking point in interviews. My advice to you is not just to get a position for a resume, but to really, if you're going to do it, get involved. That way, if it comes up on an interview, you want to be able to talk about it. So like, for example, I know, like, I've hosted 2 different golf tournaments with AMSA, like actually put everything together and ran it just to raise money to be able to take people to convention. So, being able to say that you did this and actually show leadership rather than like, yeah, I was the secretary for a year and I know how to take notes, which is great, but showing that you're really involved is important. So that's, I think, our last question here. Again, if you have questions, you can post them to the chat and we'll be answering them. I think we had one person ask, what's the best way as a DO that I can stand out if I want to do a more specialized field such as dermatology?
I guess I'll go ahead and jump on this one. So I think that if you want to stand out, definitely a couple of different things. I think you can apply this kind of broadly to any specialty, really. Do some reading on some top things. Make sure you're coming in because they're going to ask you questions, especially those type of specialties. They like to do what we call pimping. So they're going to ask you questions during procedures. It's a great way in gen surge to sweat a little extra when you can't run away or go anywhere and they're going to be asking you questions. So read up on topics that you know you're going to see. Take initiative. I think that preceptors really, really like that. So if they ask you a question and you completely flopped and you're like, you know what? I really don't know much about that topic. I'm going to go home and I'm going to read tonight. The next morning you come in and I'm sure if it's something that you're going to see a lot, it's going to come up again. And you can say, oh, I remember I was reading about this in this scenario. This patient presents a little differently. Why would you use this medication versus this? So, and I think that shows that you're committed. You're not just doing it to answer a question, but you're actually trying to learn during that rotation. So I think that that's the biggest thing, doing lots of reading, taking initiative, and not being afraid to ask questions as well.
I will say for the surgical specialties, being able to learn on the fly, being able to pick things up in a hurry, so much of it is skills based. You got to be able to do the hands-on stuff. And if you go on an audition and you show out with your hands when you're in the OR, when you're on rounds, or if you're putting in central lines, whatever, if you show that you're able to do that, that really helps. And that takes practice. Simple. That's all there is to it. There's no reason you can't go to the table and be able to close skin and be able to sew, be able to tie knots, because you can do all that stuff at the house. You can practice all those things. That goes for derm too. Any ortho, anything like that. You can practice that, and And Marcia is exactly right about the reading thing. You got to know your cases. You need to know the pre-op management, the post-op management, all the intraoperative stuff, which is fun to read about. Everybody wants to read about the surgery because you know, if you get to scrub it, you get to do it. It's a blast. You know, that's why you want to become a surgeon, is to do that kind of thing. But you go the extra mile and know the pre-op, post-op, know the complications, know how do you fix this if this doesn't work, or what are other options. Get into asking questions about why. You know, instead of asking what is this or what is this, ask why are we doing this way instead of that way. And that comes with experience. The more you do, the more you see. The more you'll see certain doctors do it one way and then another one does it the other way. And you don't ever ask like an arrogant saying, hey, this is not the right way to do it. You just ask why. And when you get to the point where you can ask why questions, it shows a little bit deeper level of understanding. And I think that goes a long way. Stuff like derm, ENT, ophtho, urology, they're still old school. You got to have the board scores. You know, we talked about getting in the door earlier. If you don't crush your boards, you're not going to get in the door for those specialties, just because they're incredibly competitive. They got to start weeding out somewhere. And the easiest apples to apples comparison they have is board scores. And so that's where they're going to start. It sucks. Personally, I hate the fact that a lot of people don't get to do what they want to do because of their board scores. I think that's a terrible way to go about it, but that's just the world we live in right now. Will they go into pass fail? That may change. I don't know how I didn't know it was going to pass fail till today. So I don't know how that'll shift things around in the future. I don't know how the one match is going to shift things around in the future. But for something like that, you gotta do really well on the boards. You gotta be ranked pretty highly in your class. Now, you don't have to be in the top 10%, but if you're in the bottom 10, it's going to be kind of hard to do. So, you know, and that starts first day of first year. I didn't realize that until I got into the application and the interview process. You know, but don't let that discourage you. I mean, I had pretty average board scores, you know, lower, I don't know, probably in the lower, maybe middle third of the class, maybe lower third of the class. And I had a couple of C's on my transcript. So, I mean, don't get down. If you get your butt kicked first semester, which you will, first semester sucks. It's incredibly hard. If you just get worn out by it or whatever, you can bounce back. You can come back from it. So don't let it discourage you. You can still, you know, overcome those things for general surgery, orthopedic surgery, that kind of thing. Derm's a different level, but you know, don't ever get discouraged. Just keep plugging along, and you can make it work.
I think that was great advice. Thank you, Brock. And we did have a DO. I think it was the class above us. It was either last year or the year before, from our medical school that did match into dermatology. So don't ever feel like you're limited by going into osteopathic medicine. You know, you're competing against everyone with the same, obviously you're taking USMLE if you're going dermatology, but you're competing against them with the same boards, the same grades and everything. I guess the only other thing that I was going to tag on was just reaching out to, because usually there's going to be someone that rotated there before you, or like last year that someone in the class above you rotated there, finding out exactly what you need to do for that rotation. Like it had been a year since I had sutured, because I had like OB-GYN and general surgery rotations pretty early third year. And then I had like my emergency medicine rotation fourth year. Like for some reason didn't really think about like how many sutures stitches they might do in emergency medicine. But it was, so we went and got an orange and I went back to practicing, and it just, it's like riding a bicycle. So it was no big deal. But if it's something that I was trying to get into as a specialty, knowing that I should probably be at home practicing that beforehand would be great. We had a prisoner come in with, I forget how many lacerations, and I ended up doing like 86 sutures. So, it came in handy, all the practice. But I think that's it for the questions. I want to just move into kind of some closing statements. If everyone wants to just share any last minute advice or tips that you have, words of encouragement before we finish for our pre-medical students and medical students.
So getting into medical school and getting into residency are both extremely challenging. Medical school has hands down been the most mentally and emotionally challenging experience of my life. But one of the sayings that everyone says through medical school is that the days are really long, but the years fly by, and it's crazy to think that I'll be finishing up here in, a couple of weeks. So just take care of yourself, take care of your mental health, and just work as hard as you can. Do your best. That's really all that you can do. And you're in this field, and you've decided to do it, and just keep going. All I gotta say.
Yeah. So
Yeah, I definitely want
obviously we said a lot about. Sorry.
Go ahead.
Okay. Obviously we touched on a lot of things regarding like board exams, and it's pretty overwhelming, especially if you're like just trying to like get through like your, block schedules in OMS 1 and 2. But I mean, all of the hard work that you're doing now is like pretty correlated to, like you're studying indirectly for board exams. So like keep your head on and do well in your classes. And when it comes down to studying for step 1 and 2, you'll actually realize that all of that hard work that you put in neuro and like the classes that you like dreaded and stayed up really late studying for have all went full circle, and now you're performing well in your exam. So it's all gonna come like to help you later on.
So I definitely want to echo what was said about kind of mental health. I think that that's really important. And it's ironic that as medical students, we have this ability to really forget about our mental health, even though that's, something we tell our patients to take care of as well, especially an osteopathic medical student, as, you have this holistic approach to medical care. So, find what makes you happy and, stick to that routine. If you are a gym goer, keep your gym routine going. If you like to skateboard, keep your skateboarding up. You are going to find every excuse that you have that, oh, I don't have time for this, I don't have time for that. Well, I think there's something to be said about taking care of yourself and allowing yourself maybe sometimes to take a night off when you're in those first and second years where, the clock is ticking and you have no idea how you're going to fit your entire schedule for what you need to do in one day. So, be kind to yourself. If you need that night off, take it. It's better for you to get a good night's rest, wake up fresh, 6 a.m., hit that setting, whatever you need to do. It's very easy, I think, to get lost in the sauce, meaning kind of like in your daily routine. Or I have this exam on Friday and I have this. Just remember that it's, this is not just a sprint. Medical school really is a marathon, and the goal is for you to be able to, have your dream job, to be a practicing physician. So, yes, focus on those things that you have going on daily, but think big picture. Think, a year ahead, years ahead to you applying to residency, matching, and being able to call yourself a physician. I think that that's a really great thing to make sure that you keep in the back of your mind as well.
I'll say this, 2 things. One, find somebody ahead of you that you can talk to about things, because I know for me, I'm the first one in my family to get into medicine. So applying to medical school was one thing I didn't know anything about. And then interviewing for medical school. And then the same thing when you start talking about boards and when to take them, that kind of thing. So I had a guy, he's a resident up in Ohio, a couple years ahead of me, went to a different school, but he walked me through all of these things. We talked pretty constantly about this strategy or this, whatever, for studying boards. And then when it came to auditions, like the away rotations, sub-eyes, whatever you want to call them, I talked to him before every single one, said, hey, this is what I'm going to be doing. What do I need to study for this? And then he comes to interview season and you go over what kind of questions you're going to get and what kind of impression you need to make and all those things. And so find somebody. I mean, our emails are there. You know, we're all here for y'all. Y'all email us and let us know what you think, or, you know, if you have any questions at all. It's a very overwhelming process. You've heard a lot of words today that I didn't know, even as a first-year student. I didn't know anything about the match. I didn't know anything about sub-Is. I didn't know anything about third-year rotations, boards, none of it. So find somebody ahead of you that's willing to help you out. Like I said, our emails are there. That's the one thing. Second thing, don't let anybody tell you can't do it. You'll have some doubt. I mean, medicine's hard. There's no doubt. It's hard to get into. It's hard to get through. I had one interview for medical school out of undergrad. I didn't have a great GPA. My MCAT was pretty good. My GPA was terrible for medical school standards. So I had one interview and I made the most of it. And then got through boards, got into third year, applied to general surgery, and the school was like, hey, you're high risk for this. You might want to consider applying somewhere else. You might want to look at doing something else. Your GPA is a little below average. Your board scores right there at average. Like, it's going to be hard for you to match general surgery. And I said, screw it. I'm going for it. And, you know, I did. I made the most of it and I matched. It's the greatest feeling in the world, being able to know that, hey, I matched into what I want to do for the rest of my life. So don't ever be scared to go for it. Chase your dream. I mean, honestly, I know it's like one of those things, but just chase your dream. It's worth it. It's a lot of work. The days are long, but the years are short. That's for sure. So go ahead and go for it.
Great. Thank you, Brock. And thank you, everyone. Those were great words. I guess my last advice before we finish would be just not to compare yourself, because I felt like I was in a similar situation as Brock, that I was the first in my family to go to, actually, I was the first in my family to go to college. And so, you know, going to medical school it didn't seem real, honestly. And I don't know, I didn't feel like I belonged for a long time. And I was really nervous about, you know, would I not make it? And just really doubting myself and whether I could even do it, even though I made it. And so if you get the interview and you're accepted, like, you did it, and be confident that you should be there. You know, you put in the hard work. So, you know, you're going to be a physician. It's a long road and it's hard. But if it's what you really want, you'll get there. So just own it. And then, you know, just don't compare yourself to others, because it's not a healthy way to, you know, to practice or to live. You know, everyone's different and everyone's got other things going on. So just do your best. And that's all you can do. So I posted all of our information here. This is all of our emails that you can feel free to reach out to any of us if you have any questions. You know, we'll do our best to get back to you as quickly as we can. I want to thank you, everyone, for joining us. This was our last event of National Osteopathic Medicine Week, hosted by the American Medical Student Association. I want to wish everyone the best of luck in their journey. I know it's tough, but you know, if it's your dream, then you'll get there. And again, happy National Osteopathic Medicine Week. Thank you, guys.